All right. Well, why don't we jump in? So good morning, everyone. Thank you again for joining us today for this webinar. I'm Adara Citrin, CHBRP's Associate Director.
Hi, I'm Anchitsa. I'm a principal analyst with CHBRP.
And we're also joined by Anna Pickrell, our other principal analyst. So today, there have been quite a few changes at the federal and state levels that will impact health insurance and health policy in California in 2026. Today, our goal is to provide an overview of those changes so you're prepared for the upcoming legislative session. Before we dive in, I'll give a quick reminder of who we are, then we'll discuss federal policy updates, followed by state policy updates. We'll have time for questions at the end, and feel free to add your questions at any time to the Q&A section of this webinar. These slides and a recording will be available on our website after this webinar. Throughout this presentation, you'll also see QR codes on slides that you can scan to see the corresponding CHBRP publication. And our colleague Anna Pickrell will post these links in the chat as well. So the California Health Benefits Review Program, or CHBRP, provides neutral and independent analysis of health insurance benefit related legislation at the request of the California legislature. We do not make recommendations. Instead, we provide evidence-based information that can be used as legislation is considered. Additionally, we provide many resources on health insurance policy, which are all available on our website. We are always available to help folks understand our work or answer questions about health insurance and benefit mandates. To give an idea of what our analyses look like, every analysis will provide some context to give an overview of what is happening at the state, federal, and sometimes local level related to the policy in question. We also give some background on the subject of the bill. We are not lawyers. We are tasked with making reasonable interpretations of each bill that is referred to us. We do reach out to ask DMHC, CDI, and DHCS questions about bill interpretation. Next, we examine the medical effectiveness of the tests, treatments, and services included in the bill by looking at existing evidence and providing a grade for it. Is this treatment effective? Is there really strong evidence, some evidence, or is there not enough research to make a conclusion, and so on? Finally, we estimate the cost impacts in the form of premium and cost-sharing changes, as well as the public health impacts on a population health level. We have videos available on our website that provide more information on how to read a CHBRP report and other good CHBRP tips. I want to first set the stage around some key facts about healthcare, both in California and nationally. The cost of healthcare and affordability is a key theme surrounding many of these policy changes. As a portion of the gross domestic product, spending on healthcare accounts for almost 18%, or about $4.8 trillion. As you can see in the chart on the left, healthcare costs have been increasing, and contributing factors include the U.S.'s aging population, increases in service utilization, and higher prices. When we look at where these healthcare dollars go, as shown in the pie chart on the right, about 31% of healthcare spending in the U.S. is attributable to hospitals, 20% to physician and clinic services, and 9% to retail prescription drugs. The average annual growth rate for these categories is also higher in recent years than it was between 2010 and 2019. Now, let's turn to what is happening in 2026. While there have been many policy changes at the federal level that will be implemented over time, we are primarily focusing on the policy changes that will have an impact in 2026. One major federal policy action was the signing of H.R. 1 in July. This federal legislation included many provisions, many of which will go into effect in 2027 and beyond. More details about the major changes to Medicaid are included in CHBRP's nuts and bolts on our website. While today we are focusing on the changes that have already gone into effect and the ones happening in 2026, there is one other change that will take effect in early 2027 that I want to highlight. Starting in January 2027, Medicaid enrollees ages 19 through 64 who gained coverage as part of Medicaid expansion will be required to work 80 hours per month to maintain their eligibility for Medicaid. We will likely see action in 2026 as states prepare for implementation. Also related to H.R. 1 in 2026, we'll see three major Medicaid-related changes. First, H.R. 1 implemented a one-year ban on federal Medicaid funding for prohibited entities that provide abortion services. This includes Planned Parenthood and other community health providers. The California Department of Healthcare Services estimates that roughly 80% of Planned Parenthood patients rely on Medi-Cal, meaning this policy change effectively strips $305 million in federal funding from one of the state's largest providers of reproductive health care. This loss of federal Medicaid funding may force Planned Parenthood to reduce services, limit appointments, or close centers, particularly in underserved areas. However, on Tuesday, December 2nd, a federal judge blocked this provision from going into effect for 22 states, including in California. This ruling has been appealed by the Federal Health and Human Services Agency. While this case continues to move through the courts, HHS is able to enforce this ban on Medicaid funding for abortion services for abortion providers. KFF released an issue brief that provides a very helpful overview of this provision and the ongoing legal challenges. Next, H.R. 1 made some changes to the Federal Medical Assistance Percentage, or FMAP, which is a statutory percentage of the federal government's share of costs for Medicaid-covered services in state Medicaid programs. The FMAP is designed to pay a larger portion of Medicaid costs in states with lower per capita incomes related to the national average, and generally ranges from 50 to 77%. For the Medicaid expansion population that states could choose to offer Medicaid to as a result of the Affordable Care Act, there is an enhanced FMAP of 90% regardless of the state. H.R. 1 will change the enhanced FMAP to 50% in October 2026. In addition, states will have to pay a larger share of costs for emergency medical care provided to non-citizens, which is covered under Medicaid. Potential impacts of these policy changes include increased state budget pressure and increased pressure on hospital finances that rely on Medicaid revenue. The Urban Institute estimates that this would result in a reduction in federal Medicaid funding for California of $12.4 billion in 2026, which is a reduction of 18%. The last major change we'll see in October 2026 as a result of H.R. 1 is the termination of federal Medicaid funding for some non-citizens. H.R. 1 ends the availability of full-scope federal Medicaid and CHIP funding for most refugees, asylees, victims of human trafficking, certain individuals whose deportation is being withheld or who were granted conditional entry, or individuals who received humanitarian parole, such as certain Afghans who aided U.S. operations in Afghanistan, or people fleeing violence in the Ukrainian war. In California, DHCS estimates approximately 200,000 immigrant Medi-Cal members will shift from satisfactory immigration status, which is eligible for full federal financial participation, to unsatisfactory immigration status, which is only eligible for emergency and pregnancy-related federal financial participation. I see someone has their hand raised, and I can't see comments. So I just want to make sure I'm not missing something, a question related to the other one, but we'll have time for questions at the end. Okay, thank you. So the next topic we'll discuss has been in the news quite a bit recently and was a major contributing factor to the federal government shutdown earlier this year. For some background, the Affordable Care Act, or ACA, established premium tax credits to help eligible households lower their monthly premiums for health plans purchased through health insurance marketplaces. The eligibility for and the amount of the tax credit is based on income. The American Rescue Plan Act expanded eligibility for and enhanced the amount of the premium tax credits for 2021 and 2022. These enhanced premium tax credits were further extended for 2023 through 2025. The federal government has been discussing whether to extend these enhanced premium tax credits for future years. However, an agreement has not yet been reached. As mentioned earlier, whether to extend the enhanced premium tax credits was a major contributing factor to the shutdown of the federal government earlier this year. The Senate and House reached an agreement to reopen the government with the agreement that there would be a vote on extending the enhanced premium tax credits. This is still an ongoing discussion, but the amount of time available to make this decision is quickly dwindling. The Federal Congressional Budget Office estimates that if these enhanced premium tax credits expire, fewer people will enroll in health insurance through the individual market, which would lead to lower federal expenditures. But it would also lead to an increase in the uninsured population. KFF recently released a survey and found that if premiums doubled, about 1 in 3 enrollees in plans purchased through marketplaces would be very likely to look for a lower premium plan, which typically includes higher deductibles and copays. Additionally, 1 in 4 enrollees said that they would be very likely to go without insurance if premiums doubled. The next federal policy change will not actually impact California, but I'm reviewing it in case you've heard about it and are wondering if it does impact California. So now you know that it won't. So in addition to bronze and silver plans you may be familiar with, the ACA also created catastrophic plans. These plans are available on or off marketplaces and include lower premiums than bronze plans, but much higher deductibles. Eligibility to enroll in these plans is limited to individuals under age 30 or who meet specified income or hardship criteria. In 2025, the Centers for Medicare and Medicaid Services released updated guidance to expand eligibility to include individuals who are ineligible for premium tax credits or cost-sharing reduction assistance and meet specified income criteria. The intent behind this policy change is to enable individuals who may otherwise become uninsured due to the high cost of premiums, due to the expiration of the enhanced premium tax credits, to enroll in a plan with lower premiums. This rule change only applies to states with federally facilitated marketplaces or states that use the federal government services to process hardship exemptions. California has a state-run marketplace, Covered California, and processes its own hardship exemptions, so therefore this rule change does not apply to insurance offerings in California. Going back to some changes included in H.R. 1, we'll see some substantial changes to the rules governing health savings accounts, or HSAs. These accounts can be used in conjunction with certain high-deductible health plans and allows enrollees to contribute pre-tax dollars to a dedicated account. These funds can then be used to pay for eligible healthcare expenses, such as deductibles, copayments, and coinsurance, but HSAs cannot be used to pay for premiums. There are current rules from the IRS that set criteria around deductible amounts and which services can be covered before an enrollee meets their deductible. Services such as preventive care and insulin are 2 examples of services that can be covered before an enrollee meets their annual deductible. Not all high-deductible health plans meet these IRS criteria. One big change H.R. 1 made is that as of January 1st, 2026, all bronze and catastrophic plans sold on or off marketplaces will now be eligible for an HSA, even if the plans do not meet the specified IRS qualifications. This will expand the number of enrollees who are able to use HSAs with their high-deductible health plans. Additionally, H.R. 1 added telehealth and other remote services to the IRS's list of eligible expenses that can be covered before an enrollee meets their deductible. This change applies to all high deductible health plans that are HSA eligible, not just a plan sold on or off marketplaces. And lastly, HR 1 removed a rule that prohibited enrollees from enrolling in an HSA if they were also enrolled in a direct primary care service agreement. These are services where an enrollee pays a flat monthly fee in exchange for their primary care. One Medical is an example of a direct primary care arrangement. HR 1 also enables enrollees to use their HSA funds to pay this monthly fee. There have been several actions and announcements from the Trump administration regarding pricing and availability of prescription drugs. While some of these changes are already in effect, others are still under development or the impacts are not yet known. One of the most significant announcements was regarding the application of tariffs on prescription drugs imported from other countries. The tariff amount ranges between 15% and 100%, and most of the US's drugs are imported from overseas. However, the administration has also focused on drug importation from Canada, which already exists. There are attempts to improve this process and make it faster, which could increase access to lower cost medications. President Trump has also negotiated agreements with pharmaceutical companies directly. In exchange for companies agreeing to price their medications at a certain level, the administration will exempt these medications from tariffs. Recently, Trump announced agreements with two manufacturers of GLP-1 medications, in which the medications will be available to Medicare and state Medicaid programs at lower prices. Announcements have also been made regarding the pricing of medications used during IVF and other fertility treatments. And lastly, Trump has announced the launch of TrumpRx, which intends to sell medications directly to consumers at lower prices. However, these prices may not be lower than an enrollee's cost sharing. TrumpRx is not yet in operation either. All of these actions are under the umbrella of Trump's goal of instituting most favored nation pricing for prescription drugs, which aims to bring prices for medications in line with prices in other developed countries. And lastly, I want to mention the Rural Health Transformation Initiative. This $50 billion initiative was created through HR 1 and provides funding to states over a 5-year period. These initiatives are led by a state agency, and the goals of the Rural Health Transformation Initiative are to improve healthcare access, quality, and sustainability in rural areas. Applications for this funding were due in November, and award decisions should be announced by the end of December. Funding will begin in 2026. In California, the Department of Healthcare Access and Information, or HCI, submitted the state's application. All 50 states applied for this program. Of the $50 billion funding amount, half will be distributed equally among all states that applied, and the other half will be allocated by the Centers for Medicare and Medicaid Services based on a variety of factors, including rural population, situation of certain hospitals, and other factors as specified. And with that, I will hand it over to Anchi to discuss the changes we'll see in California.
Thanks, Adara. All right. So now jumping into all of the things that might be happening with regard to state law. There are a couple of things that I want folks to kind of keep in mind, or I like to keep in mind when looking about changes that are coming for the year. One of the things is how are all of the things I'm going to talk about impacting cost and what potential legislation or regulation could be impacted or could come out of it. Next slide, please. So first, I'm going to talk about the Essential Health Benefit Benchmark Plan. As a little bit of background, the Affordable Care Act laid out a whole lot of rules when it comes to providing healthcare. But one of the biggest ones was that certain health plans, so non-grandfathered small and individual health plans, have to all cover 10 essential health benefits. And the way that the ACA is structured, There is a benchmark plan that all states have to use in order to make sure there's a floor and a minimum benefit coverage that covers each of these 10 essential health benefits. But then after that, the states have some flexibility in what services they can require for these particular plans. Back in 2024, there were new rules that came out from the federal government that said, okay, we're going to make it easier for states to choose what benchmark plan you want to use. And so California said, yeah, we want to do that. And this past year, we updated our benchmark, or we applied to update our benchmark and submitted a new plan in May 2025. So there are 3 major sets of benefits that are added that are proposed for our 2027 start. One is durable medical equipment. So this includes things like wheelchairs, scooters, CPAP machines. To be clear, there are durable medical equipment in our benchmark plan right now. So this would just be an expansion of what we have at the moment. Second, there are fertility services. So IVF and other services, freezing, things like that. And finally, hearing aids and exams for everybody. Right now, we are waiting for CMS to get back to us. And the DMHC director has said that if we do not have approval or some sort of response from CMS by the end of this year, which is like tomorrow, then we will likely have to delay implementation. The question, at least for me, is what does that delayed implementation look like? Does this mean that California is going to resubmit a new application with maybe new services in their benchmark proposal? Or does this mean that we're just delaying what was already submitted in May for 1 year? So we would start in January 1, 2028 instead of 2027. It's not totally clear. There was a very labor-intensive process. So I feel like it could be unlikely that we go through it again in terms of selecting a new benchmark plan, but it's a possibility. So something to keep an eye on this year. Next slide. All right, moving on to changes based on the state 2025-2026 budget, specifically for the Medi-Cal program. HR 1 did its own thing, and then the California legislature and governor made some additional changes. One of the major changes that are coming in January is the reinstatement of the acid test limits. And so basically, if you are an applicant for Medi-Cal coverage, there will now be a requirement to have your countable assets below specific limits. This used to be a requirement, then it was removed, and now we're coming back to it. The limits vary. They only apply to certain populations. So this is folks who are aged 65 or older, those with disabilities, those who live in a nursing home, or are in a family that makes too much money to qualify under federal tax rules. So this is just something to keep in mind. Just to give you an idea of what the assets covered, it's not your primary house or your primary automobile, but if you have a secondary home or a secondary vehicle or your bank accounts, that kind of stuff counts in the acid limit test. Other things that are happening in January is the enrollment freeze for undocumented adults age 19 and older who are not pregnant or postpartum. This will begin to basically limit the number or stop any new enrollment for this population. And finally, starting in January, GLPs will no longer be covered under the Medi-Cal plans. In the summertime, so starting in July, there are some additional changes. So first is there will be no more supplemental payments to dental providers. Back when the Prop 56 was passed, one of the outcomes from it, that was the tobacco tax initiative, was that there would be increased funding to existing healthcare programs under Medi-Cal. And so there were a budget appropriations of Prop 56 funds for supplemental payments to Medi-Cal dental providers for 25-26. And so there will be an elimination of $362 million starting in July 1 of 2026. There are two other changes that impact the population with unsatisfactory immigration status. First, there will no longer be dental benefits for the UIS population who are considered adults, age 19 or older. And then there's going to be a change in the clinic payments. So if you are a federally qualified health center or a rural health center that provides state-only funded services to this population, the reimbursement that you receive for those services will be lower than what it is right now. So right now there is the fee or the reimbursement is based on the prospective payment system, and it is going to turn into the applicable Medi-Cal fee-for-service rate and the applicable Medi-Cal managed care rate. Next slide. So one of the other things that are happening kind of on a statewide level, but that expands beyond just California, is that a lot of states are starting to start coordinating on their public health guidelines and public health issues independently or separately from the federal government. The main thing that we've seen so far is just states collaborating on vaccine guidelines that are separate from those provided by the federal government. But it's possible that there are other collaborations happening in the future. There are 3 alliances to date. One is the West Coast Health Alliance, which is Washington, Oregon, California, and Hawaii. In the Northeast, there are 9 states that are in a collaborative. And then there's also I think it's 12 states plus Guam are in the Governor's Public Health Alliance. And so in the press releases that have been sent out, a lot of the alliance or some of the alliances are saying, okay, we're going to collaborate on resources. If there are disasters, we're going to be able to connect. So it's unclear what is going to happen outside or of the vaccine guidelines. So it's something for sure to keep an eye on. Things like, are they going to start collecting data together? Are they going to start sharing the data and more on emergency preparedness and response? So stay tuned on that issue. Next slide. So one of the things that kind of came out of partly with the State Health Alliance was work that was implemented in California through AB 144. So AB 144 is a trailer bill, and trailer bill is just a bill that's kind of attached to the budget. The budget says you can spend this money or we're spending this money, and then the trailer bill says this is how we're spending that money. And sometimes you'll see some policy, interwoven in these trailer bills. So in 144, this omnibus bill, the California Department of Public Health was given the authority to update the state's vaccines recommendations according to certain national medical organizations. So these are the American Academy of Family Physicians, the American Academy of Pediatrics, and the American College of Obstetricians and Gynecologists. Right now, the CDPH guidelines are the same as the recommendations of the CDC's advisory committee on immunization practices recommendations as of January 1, 2025. But if you scan that code up there or follow the link that Anna's put in there, you can see a link to the latest. In addition, AB 144 did a variety of other things like help us prepare for the 2028 Olympics. And it also made sure that there's continued access to funding for abortion access and gender affirming care. And basically solidifying and expanding a little bit more on the access and coverage that is currently available in state law. Next slide. All right, on to drugs. So this has been, I think Adara talked a little bit about the healthcare costs. Drugs are really expensive, and they've been a very hot topic in not just California, but the United States broadly. And back in 2019, Governor Newsom responded and said, well, okay, we're going to have an executive order creating a program called CalRx. And the intent and goal was to partner with different drug and pharmaceutical companies to sell medications at a much lower price. And the beginning target drugs were naloxone, which is now available, and insulin, which just was announced as being available in January, yay 2026. And then finally, albuterol inhalers in schools, which is pending. So this is definitely something to keep an eye on for 2026 as the insulin is rolled out. And kind of an interesting data piece on, are people utilizing it more? Is access been improved? Just something interesting to research. Next slide. Oops. Okay. All right. Speaking of affordability, there is an office called the Office of Healthcare Affordability that was established in 2024. And the idea, it sits under HCI, or the Department of Healthcare Access and Information. And the idea with it is to help slow healthcare spending growth and improve affordability for California families. And one of the biggest responsibilities of this program is to help set and enforce spending targets for certain healthcare entities on an annual basis. The way they set it up was, okay, we don't want spending increases to be greater than the increases that California families have in terms of their taxable income, or not taxable, just income in general. And so the Office of Healthcare Affordability, or OCA, has a board and an advisory committee, and they set these targets for health plans, hospitals, and physician groups that have 25 physicians or more. And so these are the spending targets for the next couple of years. The idea is to get down to 3%, but they are trying to get, or to ease us into it. But 2026 is the first year that enforcement can actually happen. And so we're going to see how that works out for everybody. The enforcement varies in terms of its severity. So OCA can offer technical assistance. They can provide an improvement plan in conjunction with the healthcare entity that's having trouble meeting the targets. And the most severe outcome would be financial penalties if the healthcare entity was not sticking to that plan or responding to feedback from OCA. So this will be very interesting. The OCA board has the ability to be able to adjust these targets based on what's happening in the world right now. One important thing, this is a little bit into the weeds on this, but the data that is sent out annually by these healthcare entities is actually from 2 calendar years previously, or the 2 previous calendar years, to meet those spending targets. So that's definitely something to keep in mind when thinking about OCA in general. And spending targets, this is based on total healthcare expenditures. So this includes things like premiums and deductibles and all of that good stuff that people consider healthcare expenditures or spending money on healthcare. So certainly something to keep an eye on as we introduce legislation. Speaking about legislation, there is one bill on prior authorization that is beginning to be implemented this year. So SB 306 by Becker was signed into the law a couple of months ago. And the bill is trying to make a lot of changes to the prior authorization process. I'm sure you've read in the news that there are lots of people who are really upset about it. And then there are also lots of people who say it's a very critical process. And so the idea behind this bill is to try to, meet folks in the middle and try to make the prior authorization process improved. And so there's going to be a report to the regulators on all of the healthcare services that are subject to prior authorization each year. And then what will end up happening starting in 2028 is that any of the services that are most frequently approved, they will be figured out by the regulators. And then prior authorization will have to stop starting in January 1st, 2028 for those services. It is currently a temporary bill. It will sunset at the end of 2023 or the beginning of 2024. And so, this will be just really interesting. I think that the regulators have regulations or all plan letters. I'm not exactly sure what they're going to send out, but they're going to send out instructions to the healthcare entities on what needs to be submitted this summer. Another thing to keep in mind is that the departments, so the regulators, can consider the appropriateness of removing prior authorization for a specific healthcare service. So there are some factors that they can consider rather than just saying, okay, it meets this mark and you have to stop sending out prior auth. All right. Moving on to other new benefit mandates. So if you did not know before, CHBRP has this awesome reference where we list all of the health insurance benefit mandates that we have identified for each year. It's up on our website. We update it every single time there is legislation signed. And so this year we've included 4 new benefit mandates. And these are all applicable to state regulated commercial insurance and CalPERS plans. So the first one is on SB 40 on insulin. This is a cost sharing cap on a lot of different forms of insulin to $35 for a 30-day supply. So it's going to be phased in over time, but large group plans will have to, and policies will have to start complying with this as of January 1st. And then small group and individual groups will have to comply in 2027. SB 41 was all about pharmacy benefit managers and how to deal with things like costs. And so, but the one portion that is particular to cost sharing and prescription drugs is that by starting next year, cost sharing for prescription drugs can't exceed the actual rate paid by the planner policy or the net price paid by a PBM or group purchasing organization if the net price is disclosed. So some different changes to PBMs and their operations. AB 260 explicitly mandates coverage for mifepristone just to make sure that it is codified. And then SB 402 makes some modifications to coverage requirements for the treatment of autism, and basically saying that an enrollee doesn't have to be re-diagnosed for their treatment plan if they've already had a diagnosis. All right, moving on. Next slide, please. Thank you. And finally, at CHBRP, we love our mandate bills. It's our bread and butter. So there are a few that did not end up moving to the governor's desk last year, nor did they end up making it out of committee. But they were not held, as in like killed in suspense or anything like that. So they're right now just kind of sitting in purgatory, if you will, in the committee. So In January 23rd of this year, of this coming year, all of those bills need to move from the committee that they're currently in to the floor in order to continue in the legislative process for this second year of the legislative cycle. And there are 5 bills that CHBRP analyzed that qualify for this. And so there they are. I will list them out. All of these analyses are up on our website if you are interested in looking at more. And yeah, we'll see what ends up being introduced for 2026. Looking forward to it. And with that, we will open it up to questions and start going through the Q&A. Thanks so much for being here.
So looking at some of the questions that have come in, we have one comment about GLP-1 medication coverage through Medi-Cal. And this person is clarifying that the change only applies for GLP-1 medications used for weight loss. GLP-1s for type 2 diabetes are still covered. And they also provided a link, so thank you for that. Another question we received in the chat was asking about the federal Medicaid work requirements of 80 hours per week. So just to give a little bit more information about this is Medicaid enrollees ages 19 to 64, they must either work at least 80 hours per week, participate in job training, be enrolled in an education program, this could be half-time, or participate in community service to maintain their coverage. Yeah, and this will start in 2027. So we'll keep paying attention to it. We'll see how it rolls out in California. But that's a little bit more information about this requirement. See if we can find a link. Well, they say 80 hours per month, Steve. Okay, well, Anshi, we have a question about insulin coverage through CalRx and how this is available.
Sorry, trying to find the link, the mute. It should be available if you ask your pharmacist. You can switch over to the one that is available through CalRx, and so I don't think it's direct to consumers, but it is one particular brand. I think it's called Glargine. I'll throw in a link about with some Q&A from CalRx. Folks can raise their hands too if they want. It's a great question. Wait, oh, sorry. I was looking at the one on Oka. Yeah, so this is it's a good question. So right now, I think it's a little bit fuzzy. So the question is, can you explain what the Oka is currently doing to accomplish its expenditure growth targets? Healthcare premiums, for instance, are growing well over 3.5% in 2026. Very true. So like I said, what the data that they're using is from 2 years prior. And so the spending that's happening right now and the increases that are happening now might not necessarily be reflected based on the data that's being used. So for 2025, the data that was collected by Oka from the health plans and hospitals and physician groups was the 2023 and 2024 data. And so how that jives, if you will, on like, what the spending targets are for 2025 might not, it might, I've had a lot of discussions with people talking about like, how does that really work? And so I think part of this is going to end up coming out through these improvement plans and the technical assistance that OCA provides, since they're really only just getting started. So I think it's a lot of OCA working directly with these healthcare entities to hit those targets. One thing that I didn't mention, just because it's a little bit more into the weeds, is that they've also just recently, fairly recently, approved spending targets for what they consider high cost hospitals. And so these are folks, I can't remember exactly what the number is, but there's a threshold that if the spending is over a certain percentage, they would have to meet these spending targets. And I think that for the next couple of years, their spending targets are about 1.7 or 8% over the next few years. And so though what they're planning to do is identify who those high cost hospitals are each year to be able to say, all right, these folks have to lower their costs. I mean, I think part of it is we'll see how like the benefits from these actions and the improvement plans a little bit later down the road, just because it'll take some time to implement it. But it's still kind of early, but hopefully that helps answer some of your questions. Also, we can throw our emails in the chat in case you want to follow up with any of us.
Absolutely. We have a question from Nicole asking if we have specific information or resources to share with individuals living with rare diseases. Nicole, I'm wondering if you can expand on what type of information you're looking for.
Or you can come off mute. Have we done a sickle cell bill before?
Not in recent years, if we have done one. I don't know that we have anything specific to individuals with rare diseases. We have definitely done some analyses related to rare diseases. She led an analysis about pandas and pans, which is a pretty rare disease. We also looked at lipodystrophy several years ago, which now is a pretty rare side effect of HIV medications. So it comes up for us if we are analyzing a bill related to that topic. But generally, most of our other resources are geared toward a broader population.
And then I think the follow-up question on OCA was related to like the impacts of like the work that OCA is doing is lagging. I think that is correct. That's my interpretation. If you want to expand on that, please do.
Give it another minute or so for questions if anyone has others. And as Anchi said, feel free to reach out to any of us via email. We are always happy to connect and share what we know. All right. Well, thank you all so much. Really appreciate you spending your Wednesday morning with us. Uh, have a great rest of your day. Thank you again, everyone.